Okay, welcome back.
We're
close.
close.
Yeah, we are close. Let's try our technology stuff here.
There we go.
We don't want to be that close to the
A
thing.
little too close.
All right, so we are back.
Yeah, my name is Greg.
Yeah, and I'm Rick.
And healthier
ever after.
Wow.
We are here talking about how to be healthier after. We've been talking for a couple weeks about women's health, hormonal, kind of the life cycle of hormones. I don't know why that keeps technical difficulties.
Yeah.
What happens over the lifestyle? And tonight we still have Caitlin. We're going to bring Caitlin on. Here we are again.
Hey.
Thanks for being here.
No problem.
Taking time with us. She
Thanks for
is a nurse practitioner extraordinaire and very passionate about these things, and has been super helpful in kind of helping us have this conversation. Tonight we want to talk a little bit more about specifically what to do, for women, and some of this is going to be just reiterating a lot of the same things we have talked about again and again and again. But it's that important. Before starting any weight loss regimen, exercise program, dietary supplement, medication, particularly hormone replacement, we certainly recommend that you discuss that with your personal medical provider. This is for information and education only. So with that, we will get into it. There is summary. We talked a little bit last time about sort of the reproductive years and the perimenopausal decade, I guess.
Yeah.
And what
Fun
that
time.
means, and the fluctuations, especially with women, their fluctuations are much more erratic. It's not kind of that gradual decline in testosterone that a male experiences, and so it can cause a lot of crazy symptoms, come and go, and or worse, and a lot of that has to do with how it affects the weight loss. Like a lot of it affects weight gain. The things that we talked about that last time, the things that you normally have done, quit working, and all of a sudden you're on a few pounds here and there, and then you realize I really want to get into something, and so we'll talk about that a little bit, like what to do. So let's get into that. How do we start this off? I am a perimenopausal woman. What do I do about it, Caitlin?
You're a perimenopausal woman, and usually you have a few complaints, a few issues with the universe.
I have, what did you call it? The smoking gun complaints versus the
The smoking.
I have all of them.
Yeah.
You have all of them. Well, yeah, previously we were talking about smoking gun complaints. Weight gain isn't necessarily what I would consider a smoking gun, but it is in there. When women come into me and they're telling me about, symptoms and things like that. I think earlier we were talking about, my number one is I don't feel like myself, and everything's weird. I can't explain it, and they can't put their finger on it. Number two is their sleep's really janky. They're waking up at 2, 3, 4 in the morning for no good reason. No anxiety, no issues, but they fall asleep just fine. And then that third one is the weight gain. So those are the top 3 complaints I hear. And usually we say, it's just a good chat. We're talking all about aspects of lifestyle, menstrual cycles, things like that. But yeah, first things first, we always do some basics. And I think, we kind of have some notes that calls it the non-negotiables. And this is just general guidelines, but to optimize women's health, we really have to talk about different things. The number one thing is, are we moving? Are we getting exercise? Are we doing some resistance training? But our bones are only as healthy as the resistance from our muscles make them. And so if, that pull on our muscles and our tendons and ligaments and things like that, that actually tells the bone to be stronger. And so when we're losing estrogen, you're never going to have more bone mass than you have in your 30s. From then on, you're going downhill.
Yeah.
You're not, you're breaking it down more than you're building it. Right. So.
Right. And that's why, it's not, I think the way oftentimes we think about resistance training, like I'm going to lift weights because I'm going to get jacked.
Yeah.
Right. Right.
That's really not what we're talking about. It's that important though, to keep the muscle that you have. It's what we're trying to do is slow down or stop the loss that is inevitably going to happen as you age.
Right.
Because one of the big things is that we've talked about this again and again is muscles are where metabolism happens.
Yep. Right.
That's where you burn calories. That's where you're, it just it does so much good.
All the things. I mean, we're talking
Yeah.
insulin resistance and uptake of glucose. You're talking about your resting metabolic rate, which is what we're talking about. You get the amount of calories you burn to just live and breathe. And then, what Caitlin just already mentioned, your bone strength and all that. Plus just flat out how you feel, right? No one feels weak.
Right. And quality of life, I mean, we all know, because we work in the ER, when people stop moving, they fall, they get injured, they end up in the ER. And then we know falls are really, really huge. And I mean, I'm taking care of women who aren't just perimenopausal. I'm taking care of the women in 60s and 70s. They might not be doing hormone replacement or whatever, but we're still in this big realm, this big category of women who really are like struggling with some of these big issues. And I tell women, I was like, stop pushing off your chair, use your abs, like all these things. There's all sorts of things you can do to really use body weight and resistance. And, there's a lot of statistics and research out there that says there's different kinds that are better than others. And now we know, and women were always taught, you got to go for a run, you got to go do cardio, you got to be thin and lean. And no, skinny's not healthy, muscle is healthy. It's a whole shift on what we know about women's health and what keeps women healthy. So muscles actually keep us healthy. And I think, when I was younger, you'd hear women all the time like, yeah, and then I got into my 40s and my metabolism tanked. And I remember reading a really awesome book that talked about how, especially like active women and sporty women when they're in high school, or, dancers or gymnasts or whatever, we're all active through the high school years, possibly into college years. We're playing intramural sports. We're doing all sorts of things. We're active. And then in our 30s, it starts to dip a little bit. Our muscle mass, that high school, college years muscle mass kind of dips. When we hit the 40s, it kind of curves off and takes a nosedive. And then all of a sudden we're like, my metabolism just tanked. Well, metabolism isn't this magical beast that like lives in you. It's your muscles. When you lose muscle mass, you lose that part of you that's just eating calories without you even needing to do anything. And then the more you do something with them, it eats more calories. So that's a huge thing I hit with women right off the bat.
So using muscles, maintaining muscles is important. And then, here we go again, talking about also along the same lines is your protein intake.
Feeding muscles. I mean, your muscles, you can only do so much with your muscles if they don't have fuel to, amino acids. Essentially, that's all a protein is amino acids to help them grow. You can do all the working out and moving you want, but there's really nothing there to support it.
Well, protein's really important, not just for muscle retention and telling your body, hey, don't eat my muscles while I'm actively losing weight. Eat this protein, use this other fuel. But also, I know as an inpatient nurse, if you've got wounds and you're not eating good protein, you won't heal. So post-surgery, all these other things, protein is essential. And when we have a liver that stores backup sources of sugar, that's our sugar food storage is what I call it, your liver. Our body doesn't retain protein. It's not for I didn't eat my 30 grams of protein today or whatever.
Big protein store.
No, well, guess what? You do really
well with sugar and fat.
Well,
we do great with that.
In reverse, thinking about that, we actually do. They're called your muscles. So if
it's called your muscles.
Protein, you will waste.
I like that.
Your muscles. That's your storage.
That thing.
So if you don't want your muscles to go away while you're in active weight loss, I always say, hey, if you give it good protein and good healthy carbs, I'm a huge advocate for good healthy fruits and vegetables and good carbs. But if you give your body enough of that and then push it towards the fat storage, it's pointing you more towards your body, more towards using that fat storage. It's not going to look at your muscles and say, oh, well, you're not giving me anything else. I'm going to eat some muscle for dinner. And when you think about your muscles as your food, as your protein food storage, you're like, oh, I'm not doing a very good job. So
if you don't give your body that, it'll take it. And it's so important. And really, we talked about this when we did our stuff on the men's stuff, and what we just kind of dove into, because we've been doing this for the last several weeks, is, we're really just diving into the non-negotiables, really the things that are the foundation. It's like you can do all the hormone replacement therapy you want, but if you don't have a base, a foundation of some things that you're working on lifestyle wise. You can throw all the medications, all the hormones at a problem you want. And it's the catalyst is the lifestyle.
Yeah.
Is that, would you agree with that, Caitlin? What's your thoughts on that?
Oh yeah. I think that like we can do all the hormones and everything we want, but if we're not telling our body, hey, we're not just in homeostasis because we're giving it all the hormones, we're plugging in all the things that each cell needs for information. If we're not using that energy, where's it going to go? We've got to tell the body, hey, we got to keep moving, we've got to keep functioning appropriately. And so like activity, the protein, it all goes together. It's all a package deal for sure.
Absolutely. And you've talked about sleep, and one of the biggest things you notice when hormones are out of regulation, like, is your sleep. That's the like almost the first sign that you you basically, that's your first signal. Smoke in the air,
smoking gun,
smoking
gun, low progesterone.
Well, and you talk about that, like poor sleep is a result of some of these hormonal changes and low, erratic levels and things like that. But then it's like this crazy cycle, because poor sleep is also like your sleep is a hormonal regulator. You have poor sleep, that's going to increase your cortisol, which disrupts your hunger hormones and
your insulin
your insulin resistance. And so it's like a crazy cycle to get better sleep and enough sleep.
Right. Yeah. Just sleep all by itself. If we could just solve that problem, and progesterone really helps a lot of women. And we could go on and on about good sleep and the benefits of that.
Well, and we could probably do a whole episode, maybe we should, on just, it's not just like go to bed earlier. There's some like sleep hygiene. There's things you can do to manage, your light exposure and alcohol consumption, the room temperature,
not eating too late,
other
so you don't get reflux. There's a lot of things.
Sleep.
Eating, even bringing up eating even more specifically, when do you drink or consume caffeine? People don't realize caffeine has a half-life like a medication, and it's 6 to 8 hours. So if you're getting that late caffeine at 5 o'clock, you're like, it's fine, I go to bed at 10 or 11. You actually may still have the effects of that caffeine. It's really big. I had one patient that I know, she was really frustrated with her sleep, and it didn't sound to be hormonal. She was having difficulty falling asleep, not staying asleep. But and all we did is take away her 3 o'clock caffeine and move it to noon. She's like, I'm sleeping.
I've even had patients who are like, oh, I can drink a full coffee, full non-decaf full coffee, or I can drink a Monster at 7 p.m. and go right to bed. They can go to sleep, but we know statistically, like throughout their sleep cycle, they're not getting deeper restorative sleep. Just getting light sleep doesn't mean it's restorative. So that's the big word I tend to use more, as restorative sleep that's actually getting you into REM, that you're actually dreaming, you're actually processing things, and then you're actually feeling restored in the morning. Not to mention, we've got also sleep apnea. We've got acid reflux when people eat too late or they eat the wrong things. It's waking them up all night, kind of irpy burpy. We've got the sleep apnea that some people aren't even aware of, So those are some complex sleep issues. But, even on the surface, just, even some basic hygiene and moving caffeine different way. And hygiene's a weird word. That sounds like a weird word, but talking like how we're talking about not being
better
on your cell
sleep
phone
practices, or
trying
sleep
to
skills,
almost
or
choosing a boring activity before bed, like reading before bed or crocheting before bed. That's
even that like reading, one of the things that some people find beneficial, like a lot of people will read to go to sleep. So you get in bed, you read, and then you have a book that's really, really good.
I know. And you're up till 3 a.m. Right.
And I've often told patients, one of the things to try doing is don't do anything in bed that isn't sleeping. Like if you can't fall asleep and you need to read a book, get out of bed, go sit in the recliner, go sit in a chair, read until you feel sleepy, then get back in bed and go to sleep, not read in bed, because it trains your body. Like this is where I am to sleep.
Right. Or even TV. I mean, there's tons of data that says don't put a dang TV in your room. It's hard on relationships, sleep, and all the things. And yeah, I like that idea because then you can go somewhere else to watch your TV. When you feel tired, your brain knows my room is for sleeping. And that's what I do. So
that's good. It's training it.
It's a good point.
So, okay. So we get good sleep. The next thing it's we talk about this as well, but it's not easy, is you need to just reduce your stress.
Yeah, just stop stressing.
Stop having chronic stress.
Just don't stress. Is it that
That's
easy?
Cute. Oh, you guys are you cute men. That's so cute. That's not how women work.
So cute.
Yeah.
I just want to pinch your little cheeks.
Can you just turn it off like a light switch?
Oh, totally. Because me and my 5 kids and all the chores they're not doing and all the food they're eating me out of the house.
2 jobs, 5 kids.
Yeah, there's nothing to stress about. My home, my yard, all that stuff. No.
Well, what can we do? I mean, specifically from your perspective, and even more specifically on the women's side of things, because we give this perspective as medical providers and as men, but like, is there anything specifically that I know you kind of hit on some stuff last episode about some of your advice about self-care, but anything specifically that you could add to that as far as the women you see and stuff that you're like, hey, these are the things that I think are like, I know I can't take away your stress, but like, how can I at least reduce it?
Yeah, there are things that can help reduce it.
Those are, like I said, there are some non-modifiables. I mean, you can't control if your like mother-in-law passed away or if somebody crashed into you in the car. You can't control if, your husband's work is a pain in the neck, or you can't control that thing. So we always focus on the things we can. And I tell women, look at your body, look at your life. Give yourself kind of a theoretical hug and say, hey, this body, I only have one of them. It's given me beautiful kids, if that's what you've chosen to do. It's taken me on amazing adventures. I'm able to help people. I'm able to serve. I'm able, whatever's gone on in your life, give yourself a hug and say, hey, listen, like, we got to start taking care of this long term. There's a reason life expectancy is into our 80s. If we're going into menopause, in our 50s, we got 30 years. And personally, I don't want to just live till I'm like 90 and be miserable. I want those to be really good, healthy, productive years where I'm a great grandma, and I'm doing all sorts of fun activities. So talking to women and saying, chronic stress will kill you. We know that those elevated cortisol hormones literally decrease your immune system. They change your cardiovascular risk profile. It's all sorts of things. So when I talk to women about it, it's mostly start saying no with love. Just look at what's on your plate and say, these are my kids. This is my job. This is my relationship with my spouse. Everything else is just extra. And if I've got to say no to some of those things so that I can recover, so I can rebuild back after a stressful event or illness or something happened, it's okay. And we need to start supporting each other in that as well. And when I can look at a woman who's an amazing wife, an amazing mother, an amazing daughter, and all these aspects, who never has told anybody no in her whole life, she literally feels like she's breaking a bone by saying no to somebody. And if we don't start supporting people and saying, hey, let me take this off your plate. You can say no. You get to say no for your future. And I think that's huge for women. And the more men that say, hey, honey, no, I'm taking this off your plate. You do so much around this place. You do so much for our family. Take some stuff, unburden them a little bit until these women can start saying, hey, I would love to help you with that, but this isn't going to help me or my family out right now if I do this. So it's tricky because literally women's eyes fill up with tears, these amazing women, and they don't know how to say no in a nice, kind, loving manner. So.
I tried that with my wife. I said, hey, let me take that off your plate. She says, no, that's my creme brulee.
Smart woman. See, she knows what's important. She's got what.
But there are some positive things. And this is almost like when we talk about medications and specific hormone treatments that are really individualized. Yeah. When we talk to Cliff about compound pharmacy, like it's getting the right dose for the right patient at the right time. There are some active things that people can do. And this is going to be different for everybody, but you can sometimes find a thing like, things like meditation or time outdoors, hike in the woods,
100%.
Social connections, talking with a friend, deep breathing, journaling, like there's activities that that are active, positive things that you can do that have clinically been shown to have a measurable physiologic effect on reducing stress. So, we don't want to forget about those things. And again, that's going to be an individual thing. Like what is it that you can do that will do that for you?
And I talk to women a lot about, like, hey, what have you always wanted to do? What are your hobbies? And they're like, well, I clean my house. And I'm like, that's not a hobby. No, that's not a hobby. Like, I'm talking like stuff that you've always craved, you've always wanted to try, you know what I mean? Because getting women to think outside the box, hey, your babies aren't babies anymore. They can make themselves a sandwich. You go do something with a girlfriend, go out to lunch, go take a painting class, go read a book in a park somewhere, turn your phone off for an hour. You can do this, and I think that's huge. Like, just these self-care things, us women, we tell ourselves so many things like, oh, that gym membership, it's going to cost so much. And, but, I don't have a friend to go with to yoga. And it's like, there's all these things we tell ourselves. But once we start getting empowered and brave and saying, no, you know what? I've always wanted to try that. I'm going to go try that, and, whatever the activity is.
That's
and
great.
It's huge. It's amazing to see transformations that way.
And then finally, on these kind of lifestyle things, we could probably talk a whole nother episode on the Mediterranean style of nutrition. I mean, there's some things. This is real foods, healthy foods, beans, whole grains, those types of food choices. Can also help with this. Let's get into then. So those are the kind of the lifestyle things that are we call it the non-negotiables. Those are what we start with. Those are things that we really want to have as kind of a basis for our
good
healthy
foundation.
Lifestyle transformation.
But
now let's get into, okay, after I've got those things going, it's just not quite enough. What are the hormone therapy options? Like, some people just really do need to replace some hormones, right?
Right. And I always stress to women, there's some amazing unicorn women out there who never have had a hot flash in their menopause journey. They've never had any of that. They've never really had miserable symptoms. And I don't know what it is, but it's magic. So even if, and this is the first thing I want to say, even if you don't have symptoms that are debilitating, even if they're just kind of bothersome, or even if you've never had the dreaded hot flashes, there's still chronic illness like trending underneath the surface. Just because you don't have hot flashes doesn't mean you're not going to have bone loss over the span of your lifetime. So hormones are very considered preventative. It's not just symptomatic. Most of the time, it's the symptoms that get the women in the office, taking time out of their busy lives to come deal with it. But it still is preventative to get us to the 80s and 90s and, not having brittle bones and stuff like that.
So we're not thinking about hormone therapy options only as treating the symptoms I'm experiencing during perimenopause, but it is really preparing myself to remain healthy for a much longer
maintaining metabolic health, maintaining cardiovascular fitness, maintaining muscle mass, which is only going to help with everything else, maintaining bone, eye, joint health to keep us moving so that we can keep ambulating so we don't have falls. It's multi-system. So it's not just symptom control. There are women out there who are magic and never have symptoms.
Well, this is what I'm hearing you say. Sorry to cut you off, Caitlin. The thing that I'm hearing here is that we have this lifespan. We know we're going to all live to be, heaven forbid, an accident or something rare that happens. But if we can make it into our 80s, the idea behind some of this hormone replacement therapy for women is that we can get into our 80s in a good way. Like, not that we're just barely making it into our 80s and the last 5 years of our life is miserable, but actually can we get into our later years? And so maybe, your last year of life is a little bit rough, but not the last decade of your life.
Right. I like to say we're not limping into our 80s. We're blowing right into them on, like a race car wheels.
Because it's arguably, it's much easier when you think about this, where the science is right now. This may change, but with peptides and hormone replacement therapy and all that stuff, it's much easier to think that it's going to be easier to improve the quality of life before we can start lengthening life. Like, we could probably improve quality of life easier and sooner. We probably have the technology is here to improve your quality of life before it is to actually lengthen life, where people are living healthy into their hundreds.
And there's, that whole cohort that got hormone replacement snatched away from them, from when
we see the effects of that.
we're seeing that in the ER. There's still, in Southern Utah, the life expectancy for an average woman is 84. So they're still living a long time, but that last 10 to 15 years is chronic UTIs, bone breaks, vertebra, stress fractures. Yeah. There's a lot of problems with that. And personally, I don't know that I need to live past 84 or 85, but I don't want that last 10 years to be miserable. I don't want that. I don't want to be a burden on somebody. I don't need to be in a care facility.
It's quality over quantity.
It is. And I'm okay with having quality over quantity. If I get quantity and it's excellent too, then that's fine too. But
there you go, Rick. What? Why did it, when it said quantity and we started talking about old?
Well, it just about quality. He said quality and it went right to.
No, I think it was the old. It goes right into Rick.
Wow. But yeah, I think when we talk about different, we were talking about hormone therapy options. So it's not just and obviously I love it when patients are making their own choices. I give them good information so they can make the best choice that works for them, that's tolerable, that works with their life, right? So it's not just, but I'm definitely forward with the fact that even without symptoms, every woman's body requires a little bit of something to carry it along, to keep it from eating more bone than more bone than it's building in, etc. So, but when we talk about hormone replacement options, just starting out with estrogen, one of the big contraindications, I think we talked about this last time, was an unprovoked DVT and PE. Well, what does that mean? It means that you have a clot in your leg or in your lung that we can't explain. We can't figure out why. And we don't ever want those, right? But they're more common after surgery. They're more common after you've been on long flights and things like that.
Yeah.
And I think that with estrogen, the biggest improvement we've seen with estrogen is now we have therapies that essentially don't raise your clotting risk at all, which was the big fight, which is why women shouldn't be on, one of the big fights, why women shouldn't be on estrogen and things like that. We have transdermal options, we have gels, we have foams. Personally, most of my patients really appreciate, hi, Rick, right as I talk to women and talk to people about women. But I think that my patient's favorite is topical, a estrogen patch, essentially. So there's lots of forms, there's lots of brands. Sometimes the patch is kind of big and it's circular. Sometimes it's small and rectangular. Every woman's body is different. Every skin type's different. Sometimes one brand of patch loves to stick on a woman's skin and the other brand doesn't like it. So I always tell women, hey, I will do whatever to see if transdermal, the patch, will work for you the best, because it's the safest option by far. So fiddle around with it. Talk to your pharmacist and take your box and say, hey, I had this brand the last time, whatever brand or, manufacturer. I didn't particularly like it. Do you have something else that's the same dose? And try a different size patch. And I guarantee it might take a month or two, but women come to me and they're like, this one is sticking on me perfect, and I sweat and I sit in the hot tub and da da da. So I feel really confident that for most women, we can find you a patch that'll work with your skin, whether it's too dry, too oily, too sensitive, to whatever. And then once we find that manufacturer, I'll just specialty order it. We'll go mail order. It'll come to your house every month. It's a lot cheaper anyway. You know what I mean? So there's plenty of ways to keep it very safe. There's also a pill form. Some of my women who've been on hormone replacement for a time, their provider started them on the oral form. I always risk assess for any kind of clot issues, anything like that. And if they choose to try the transdermal, it still has a very low risk of clotting events, breast cancer, any kind of exacerbation stuff. But and if they want to try the transdermal, because they're like, hey, I only have to change that once a week, I don't mind that. So they'll try it. And sometimes they say, I kind of like the pill better. I just remembered it easier. And that's okay, because overall risk is still very low in hormone replacement with estrogen, because it's such a tiny dose. It's not birth control doses. So there's lots of forms of that. There's also creams and stuff like that. Once women kind of find a dose that they like, you can have it compounded. I prefer to kind of keep things separate until we find a dose, because every woman likes a little more progesterone, a little less estrogen. I like to keep things separate, but eventually people can choose to do a combined medication, have it compounded, whatever, if they want to keep it simple. It's a lot more expensive that way. Insurance doesn't usually love to cover any of that.
Your estrogen and your progesterone both, but you're saying it's probably better or to individualize each of those separately.
Yeah, at least initially.
The simple combo formula.
And when you think about it this way, if we're starting more hormone replacement in perimenopause, you're still making your own hormones. So what we're giving you right now, in a couple of years, we might need to incrementally go up with your estrogen and go up with your progesterone. So we might still have to tweak, fine tune things, you know. I mean, theoretically, once a woman's in menopause and she's like, let's rock and roll this dose for the rest of time, then it's like, hey, you can do a lot of things with that. But it gets a lot more costly. It gets a lot more complicated at that point, but it's doable. And I've known some women on certain creams and different compounded formulations. But yeah, I like keeping it separate. And usually it's a lot more cost effective.
So those are the two big ones for women. Now let's talk a little bit about testosterone.
Testosterone. This is one that is like commonly thought of just as a male hormone.
Right. Commonly thought of for, like, obviously testosterone is commonly thought of as a male hormone. Obviously there's some dosing considerations and things in women. Women do make testosterone. We make a small amount. Obviously in situations like PCOS, their body may be making more testosterone, which is
did you mean PMOS?
PMOS. Oh, you're right. Yes. I need to get with the program. I finally got a new name for it. I need to use it.
A couple of weeks.
Yeah, it's been that change.
I know. It's hard to get my brain around it. So when I have women come in and they have symptoms of maybe PMOS or facial hair, acne, weight gain, just different things like hidradenitis, things like that, then I kind of start looking at, okay, what is our testosterone level? I like to check that and kind of get a baseline number. That's one of the few things in perimenopause that I kind of like to see a number so I can kind of adjust and we can associate symptoms with. But really, obviously for women, the most common form is a gel or a cream. Most of the time, you know, when women, like, for example, the most commonly prescribed testosterone cream that I do for women, it comes in a compounded formulation. It's a cream, but it comes in almost like a gel deodorant stick. Have you ever used one of those where it like clicks and it squishes up a little amount? Yeah. So this testosterone cream, most women do really well with it. And I say use 1 to 2 clicks. So start out with 1 click. And I say when you get in the shower in the morning, shower, wash, you know, you get out, you put your deodorant on, put your testosterone cream right there. Like, not right there, sorry. Usually in the groin area or in some out of the way place that you're not going to like necessarily rub up against any animals or any people that way. But it's if you're consistent with it, I get the most consistent results out of it to where I know exactly what your numbers are going to look like at 6 to 8 weeks. And usually it's a pretty strong, you know, bump. Women don't, it's just like with men's testosterone, they don't necessarily feel this huge surge of whatever overnight. Usually at about 2 months, they're like, hey, I do feel better. Hey, I've noticed libido's increased, my muscle mass. Okay,
and the dosing for women is going to be much less than you would for a male patient.
So
that's again a case for very individualized care. It's also worth noting that testosterone therapy for women is not currently FDA approved in the United States.
Correct.
There's good evidence. There's increasing evidence that supports it, the benefits, but it's considered an off-label usage.
Why do you think that is, you guys? Why do you?
What's that?
Why do you think it's optional? Even though I make testosterone.
We know the answer. We know the answer to that. No, it's the same reason why we did one trial in 2002 and it just was shut everything down because it was honestly easier rather than to look at the study and say, hey, wait, what did we miss here? Over 40 years, this was great. And then over one study in 9 months, this got bad. It's the same reason, right? It's like, you know, it's just predominantly, it's just easier to tell women to buck up. And that's just how you feel now. And then it is to say, hey, there's a problem here and we're missing something and let's look into it. Now, I do think that's changing and evolving. I think that,
for sure.
I do think it's getting much better, but I mean, predominantly it's been males running most of the medical organizations, trials, and everything else that we do in healthcare.
right there. And we're finally getting more women
This is why we
OBGYNs.
invited Caitlin.
Yeah, this is
to be on here.
this is why we invited you.
Because
sassy.
it's
That's why. And I just needed somebody to say it. It's just the beast in the room. And I think that we're getting more female providers in the workforce. We're getting more female OBGYNs that are saying, hey, this doesn't make any sense.
Yeah.
And we're getting more women in general in the workforce that are like, hey, I'm not dead just because I'm done having babies or I didn't have babies. My health matters. And we have more of a voice at the table.
So you've mentioned previously about the girl parts. And I think that's where there are some people that can't really tolerate or aren't really candidates for like systemic hormone replacement, but there's vaginal estrogen that helps a lot with kind of some of those things. It's not the same as the systemic stuff, but it's helpful in some patients.
Right. And I wouldn't say that I've never had a woman not tolerate hormone replacement medications, which sounds crazy. Now, they might not be appropriate, but I've never had somebody not tolerate it because they're at such a low dose. Even if they felt like garbage on birth control when they were in their 20s, those are such high doses. The hormone replacement, I've actually, especially stepwise and titrating and making sure everybody feels good, I've never had somebody not tolerate it.
Perfect.
So, but I would say on the flip side of that, there's some women who are inappropriate for hormone replacement therapy. So like those women who have gone longer than 10 years postmenopausal. So after that 1 year of not having a period, that starts menopause, and then 10 years. So they've got that window. They might be inappropriate for it. It's a conversation. Additionally, women over the age of 60 to 65, they say, hey, even if, say, you went into menopause at 57, theoretically your 10-year window, which 57, wow, that's pretty, that's late, but I've seen them. I've seen women that way. 57 to 67, maybe after 65, they're saying maybe we shouldn't be starting it even after 65. We still might have like cardiovascular disease and other issues that we would wake back up and wake the beast up. So there are certain considerations that way. So that's always a risk versus benefit. It's always a conversation with the patient. It's looking at lifestyle, activity, health, overall health, and things like that. But that's one of those considerations. And if there are women who are like, you know what, they just don't fit that bill, or risk versus benefit, it's not appropriate, I say, hey, but guess what? You know what's appropriate for everyone? Vaginal estrogen, especially for women, to prevent UTIs. We prevent like the loss of that subcutaneous fat and the blood flow and all those parts down there. So
atrophic vaginitis, so dryness, and then chronic recurrent UTIs.
Right. And not just the dryness, but atrophy. It's literally like, we all know going into the ER, like I was an ER nurse, like when we go in to put in a catheter in a cute little old lady and those parts aren't in the same place, things move drastically. It's also including like pelvic floor therapy. We've got to do a lot of stuff. That's some major organs down there that move and change just because we're not getting a lot of estrogen all of a sudden. And so, it's not just dryness and intimacy issues and I'm getting chronic UTIs. It's also just structure changes altogether because of atrophy. We're losing blood flow, we're losing subcutaneous tissue, because blood flow means that tissue is just going to kind of dry up, get really friable is the medical term for just really thin paper-like tissue. And it's painful, even to use toilet paper just after to go to the bathroom. Women are like, it hurts so bad, it's like sandpaper. So that's incredibly a big issue for me. That's not just quality of life, that's potential like UTIs. And we've seen plenty of UTIs that go really, really bad on these poor women.
Which become dangerous as you age.
Right. Definitely. And I mean, like, you get enough of those and we've got some chronic issues. You're on chronic antibiotic therapy, which isn't super great. Nothing we want to do. And I've had patients who I've prescribed vaginal estrogen for, and within a couple months of doing a follow-up, they come back and they're like, I cannot believe it. It's not perfect, but oh my gosh, like everything's so much different. I didn't have my UTI this month. And I like, it just doesn't hurt to like pee. Like, just that, and so these poor women are just happy with that. So if that's all we can do, that's amazing. I still prescribe vaginal estrogen for women who are even doing systemic therapy. And you would think like, why, if the hormone's going all over in my whole body, why would I need it down there? Some women, like I said, just need more estrogen, need a little bit less or whatever. And if we're only booping up their levels a little bit systemically, maybe they need a little bit more like locally and topically. And so I always give that to women just because they'll notice. They notice. You guys would notice if your parts were changing. They notice. And so I say, hey, go ahead and use like pea-sized amount and just, daily, if that's what you want to do. You'll know if you need it or if you don't. Yeah. So they always have that on hand. So I think it's a huge one. That's a huge resource.
I know.
Well, great.
Yep.
What else we got?
Well, I think the last one would be, with all of this, we know the body starts changing. Me and Rick are huge advocates of metabolic health and weight loss. And that's kind of really what got this whole thing going. And we know that this is all related. So can you just give us a brief summary of what you're seeing with GLP-1s and all the things that come along with this peri and postmenopausal state?
I do. For most of my women that come in, I would say probably 3/4 of them aren't even wanting to deal with weight loss. They just know something's not right, and they know the weight loss will figure itself out, and that'll be a later discussion. So a lot of the times we don't even go there. I do my basic vitals and my weights and stuff like that, but I really have to read the room, because when you walk into a room and your only focus is, well, you've gained weight. They've heard that from plenty other male providers. Like that's kind of, they've done that, been there. But, and they're doing the best they can. So about 3/4 of the women I talk to, yes, that's a complaint, but that's not something they actively want to work on. The other quarter, it's all part of the same conversation. We just do what we need to do at the time. But I think with GLP-1s, I mean, guidelines are saying, hey, metabolic support is essential to prevent chronic disease, chronic cardiovascular disease, insulin dependence, or insulin resistance, and things like that. So I think that GLP-1s, the way I use them with my patients, is I say, hey, give your body a hug. We're doing a lot of all at once. We're stabilizing hormones, and eventually we kind of work into this GLP-1 weight loss kind of situation. It's not wrong. All of the resources are saying GLP-1s are excellent at maintaining metabolic health. And so when I talk to women though about it, I say, hey, low and slow. We like to have a little bit of GLP medication that we like to fine tune that low dose as low as we can get you to where you're still hungry for good protein, clean eating. Eating still sounds great. We get a lot of dopamine from eating. We still want to be able to eat, but we're just having help with the snacks. We're still having help with just not feeling like, man, everything's going on and I'm just snacking and I just got to go like run to my snacks. So I use it very like low dose, low anti-inflammatory kind of settings, to where it's just meant to be one tool in the toolbox. There's lots of tools in a toolbox. It wouldn't be the most optimal to use a hammer if you need a screwdriver, right? So GLP-1s for me is like the hammer. It's great for some things. It's not everything. We got to use all our other tools. We got to do our resistance training. We got to manage our hormones effectively, manage stress, self-care, all the things, because great, GLP-1 might help with a little bit. It might help you manage weight, get to a healthy goal range. And we discuss all the ways, all the monikers of a healthy goal weight. But also we got to use all our other things. So absolutely, I use it in a holistic setting, whole patient centered care kind of setting. But it's all part of the conversation. But I don't push it if that's not really their priority at the time, and they kind of want to work on hormones and stabilizing things, feeling like they're not growling at their kids for every little thing, and they're sleeping better, because a lot of women feel like, hey, I feel like I could focus on losing weight and being more active and eating, with or without a GLP-1, if I just felt like everything else kind of felt better. So,
okay, awesome. Well, thank you. So, summary, I guess it would be, so we have the tools. There's plenty of tools. The tools exist. Evidence is growing about their benefits. And it sounds like what, I guess, summarizing, I would say the most effective approach combines lifestyle as a foundation. We talk about these, the non-negotiables, lifestyle changes in a sustainable way, along with targeted therapies individualized to a woman's personal kind of history, goals, and biology, which is really an individual thing. So start the conversation with your provider, and if they're not having it, find someone who is, because it really is. It's something that takes, as Caitlin was saying, it's something that takes a lot of effort to maybe get to the right therapy, the individualized care that you need at this time in your life.
But it's worth it in the long run. It's an investment that pays off for sure.
Yeah.
So
Awesome.
Yeah.
Well, thank you for being here with us. This has been a fun little series of episodes, and we may have to have you on again when we get stuck on women's things again.
Hey, yeah, you can say no to a lot of things, Caitlin, but don't say no to us.
Right.
I wouldn't dream of it.
Please.
You all know me better than that. You know that I could say no. I can be sassy. No,
all right. Well, thanks so much. And again,
No
our
problem.
hope is that this is helpful advice, and
Yes.
everyone here listening can get and remain healthier ever after.
Yep.